Chronic myeloid leukemia. Etiology and pathophysiology. The occurrence of chronic myeloid leukemia, CML, is regarded as sporadic. No significant risk factor has been uncovered for its development, except previous high-dose ionizing radiation. CML is the best studied molecular model of leukemia as it was the first neoplastic process to be associated with a consistent acquired genetic abnormality. The crucial genetic event in CML is the generation of a reciprocal chromosomal translocation between chromosomes 9 and 22, the so-called Philadelphia, pH, chromosome, in a hematopoietic stem cell. This translocation creates new genes, one of which is BCR-ABL on the pH chromosome. The end product of this genetic rearrangement is an oncoprotein responsible for most of the phenotypic abnormalities of chronic phase CML. The fusion proteins are activated tyrosine kinases. Epidemiology. The incidence of CML, stable worldwide, is 1.5 per 100,000 population. The median age of onset is 40-50 years, but CML can occur at all ages, with a variant form occurring in childhood. Males are slightly more commonly affected than females. Clinical presentation. Common: bone marrow failure, anemia and thrombocytopenia. Hypermetabolism, weight loss, anorexia, and sweats. Splenomegaly, abdominal pain and bloating, in 60–80%. Rare: leukostasis, visual impairment and priapism. Hyperuricemia, gout and renal failure. Investigations and staging. A leukocytosis of 5400x109/L is found, with a full spectrum of myeloid cells represented in the peripheral blood. Increased numbers of eosinophils and basophils. Reduced neutrophil alkaline phosphatase. Normochromic, normocytic anemia. High platelet count, but this may be normal or reduced. Serum uric acid is raised. Serum vitamin B12 and vitamin B12 binding capacity are increased. Bone marrow is hypercellular with granulocytic predominance. The pH chromosome, and BCR-ABL fusion protein, can be isolated from blood or bone marrow. The disease course of CML usually starts with a chronic phase which lasts for 2 to 5 years. An accelerated phase follows when blood counts become difficult to control. Blast transformation follows soon after, as the leukemic problem is in an early stem cell. Transformation can be to acute myeloid leukemia, AML, or acute lymphoblastic leukemia, ALL. Patients may present in any phase. Treatment. NB. Emergency treatment is not often needed, but may be required if there are symptoms of leukostasis when leukapheresis should be arranged urgently. Tyrosine kinase inhibitor, imatinib. The management of CML has changed dramatically since this agent was introduced into clinical practice in 1998. Owing to the ability of this drug to keep the BCR-ABL molecule in an inactive configuration, it is able to reverse the blood and marrow abnormalities rapidly, and can clear the cytogenetic abnormality, pH chromosome, from the bone marrow in up to 80% of patients. However, this drug is not thought to offer a cure in most patients, as withdrawing the drug results in return of the abnormalities. It is therefore necessary to continue the drug long-term in those who achieve a good response with minimal side effects. Side effects are generally mild and include nausea, fluid retention and, in a few cases, neutropenia or thrombocytopenia. Occasionally these are severe enough to require reduction in the dose or complete withdrawal of the drug. The side effects are reversible. Transplantation. The only treatment with a prospect of cure for most patients is allogeneic stem cell transplantation. Currently, most patients will commence treatment with imatinib and progress to transplantation only if they do not respond. However, there remains a good argument for offering an allograft early in the disease for fit patients with a human leukocyte antigen-matched sibling and donor. Prior to cytotoxic therapy and, in particular, stem cell transplantation, all patients should be offered the opportunity to cryopreserve sperm or oocytes. Other therapies. Newer kinase inhibitors are in clinical trials. Alternative treatments include combinations of chemotherapeutic agents, interferon alpha, and autologous stem cell transplantation. These are used with far less frequency since the introduction of imatinib, except for hydroxycarbamide, hydroxyurea, which is still often used as a cytoreductive agent when the patient first presents. Accelerated phase and blast transformation. Transformation to AML or ALL will eventually occur in all patients who have not had curative treatment. Treatment is with chemotherapy. In a few patients a second chronic phase is restored, but in the majority the treatment can only be hoped to prolong life slightly. Transplantation typically has a poor outcome in this setting. Prognosis. In the chronic phase of chronic lymphatic leukemia the median survival time is 2 to 5 years, although patients often survive longer. Once the transformation to AML or ALL has occurred, the survival period is typically 3 to 6 months.